Look, you have this many categories in shoulder. So if I want to look up this pulley, easy. All kinds of different planes that they're going to do this in, taken from different, all that stuff. All right. Now we expect you to know some of this off the top of your head as well, but you can certainly reference this.
Like during our session.
I've got no problem with that.
Like having our phone.
Yeah.
And having this with
Yes.
Just making sure.
The more you ask him, he's probably not saying
I would
no.
be thrilled if you could find this on your phone and say, this, show a patient, this is what I want you to do. That's essentially what we're
Right here.
They were using it in the clinic as, like, they were just, having a computer.
The way I usually do this is I'll say, okay, we worked on this during the day. I'll click on the 3 or 4 that we did, print it off for them, or send it to them, how if they like it electronically, or if they like it printed out, or whatever. But I want them to have something to reference at home. Okay, this is a great site. I mean, and again, you can look at the lumbar. It's like, who's on for 3 days? They even got pictures of mobilizations, self-mobilizations, all kinds of stuff. So anyway, have fun with that. All right, so looking back down through shoulder before we leave it completely, I've put a couple articles on here. There's one that's a standard of care, talking about what you do with AC joint separations. Again, this is more for your information. It's not that I'm gonna test everybody on these types and all this kind of stuff. This is something, if you had somebody 3 years down the road, you can come back and say, oh, I remember Dr. L talked about this paper about AC joint separation. Maybe this will help me develop a better program for them. There is an article that I want you to look at. Shoulder Muscle Activity and Function by a friend of mine, Rafael Escamilla. Recognize James Andrews on here, Dr. Andrews. This talks about EMG studies, meaning electromyographic studies. They put needles in people and then have them do exercises. And through the readouts on the EMG, they can say, well, this exercise works this muscle better than that exercise. So if they ask you to be in the study for these things, know that they're going to be putting needles into your rotator cuff, which is not a whole lot of fun. But I definitely would recommend reading this article. It will be helpful to you. And you can just kind of look at the summary of it too. You don't have to sit here and do everything. But look, it lists the exercises right here and which muscles get the most readout. And this you'll see this a lot on research articles. Percentage of maximum volitional, what's the I gonna be for? Something contraction. Voluntary isometric contraction. So what they're doing, they will put that muscle in a manual muscle test, and they will take the dynamometer that we've showed you and push against it as hard as you can. And that equates to 100%. And then they'll have somebody do an exercise, and this will give you the percentage of that maximum volitional isometric contraction. You'll see that a lot in articles. So that can be helpful. I don't want you to memorize it, I just want you to read it and be familiar. It's a 24-page article. Won many, many, many awards. And then I also put a few of these protocols on here. This is a doctor that now is at Stanford that I worked with when he was at Wake Forest. Here are all of his protocols, and he is very research-based. He's going to do the latest and greatest things. So these came from about, give or take, 6, 7 years ago. So they may be a little bit outdated, but again, he's a cutting edge guy. These are all up to date for the most part. But But you can look through his rotator cuff repair protocol. He's got even days listed here. This is a detail-oriented dude. He and I did a presentation this fall in Atlanta on labor. And it was really cool. We had 2 orthopedic surgeons, he's the director of sports medicine for Stanford, and then we had the team doc for the Phoenix Coyotes and what's the football team? Cardinals. And then myself as a PT, and then the PT from Greenville, who does all the research. She's a research PT, and did an incredible job of breaking all this stuff down in terms of labor repairs and so forth. That was really good. Here's his bicep tenodesis protocol. Does everybody know what biceps tenodesis is? We don't really talk about it too much. That's when they take, so we got 2 heads, right? Comes up through here, short head here, long head here. Long head attaches to the labrum, right? It gets frayed, it gets pulled, it gets tugged, it gets damaged. It sits in that groove. We talked about how it fits in that groove. And you go like this and you can feel it in that groove. Well, that groove becomes, that ditch can get a bone spur in it, and it starts to fray this, okay? So a lot of times what they'll do is they will just cut it. They will cut that biceps and they will move the insertion down. They'll move the origin of the biceps down, and they'll suture it to the bone about 2 inches down from the labrum. So the theory being, you're not getting all the tug on the capsule, okay? You don't get the damage to the labrum because the biceps is no longer attached there. Now, they don't just do this to anybody that doesn't have pain or anything like that. But if you see, and I saw a lot of throwers and so forth, this is very common procedure. They can, what they call a tenodesis, where they actually apply it to it, or they can just cut it. And that's called a tenotomy, where they just cut the tendon and let it flow. It balls up down here. Still no big deal because you got the other one. And you got brachioradialis and brachialis and all these other elbow flexors. So you're in good shape there if you lose that. The thing about a biceps tenodesis, and the doctors never tell your patients this, I had one the other day, it hurts like hell. Because they cut this thing, and it doesn't hurt to cut it. It hurts when they anchor it to the bone with screws or buttons or whatever they fixate. But I mean, you talk about drilling into bone, hurts a lot. And they'll have a rotator cuff repair, and that's usually pretty painful. But it's the biceps tenodesis that they're like, oh my gosh, that hurts so bad. And it hurts for so long. A month of just bone pain, okay? They don't tell them that. They wait till we get a hold of them. So that's a good one. And again, I don't want you to memorize these things. I want you to have these for reference. And you can compare them to places you go. Say, hey, this is what they did. Why are we more aggressive? Or why are we more conservative? Just something to ask. There's 23 pages of these things. Here's a total shoulder. And look, he describes these things very well. What you should expect, okay? Passive range of motion is not stretching. He's really good. Very, very PT oriented. He would call me and say, I'm gonna do surgery on this guy, you have a month. If you can get him better in a month and not do surgery, that's awesome. If not, I get to cut off. So that was always fun. Here's labor repairs. And this is a shoulder guy. This is all he does. Occasionally do an ACL, but this is the bank card repair. Let's see what else we got there. That's it. Okay. Those are definitely worth holding on to. All right, can we leave shoulder in the dust here? Throwers exercises, no we can't. Sorry. This is Kevin Wilkes Thrower's 10. That's what we watched in the video the other day. And I think it adds up to 14 exercises. It's not 10 anymore.
He just did one for softball.
Was that?
He just did one for softball.
Yeah. Yeah. So again, you'll see these all over the place. These I would commit to memory. You need to know these. These are super basic. Super basic. I do every one of these. With the exception, I don't like this one. Because most of the people I'm working with, they go over their head with things that creates more impingement. I'm not a, if I've got a weight and I press it over my head, this EMG is off the charts for rotator cuff. But I don't think you get the, you have too much risk to get the bang for your buck there. I would rather work people down here and like, I always tell them, like, hey, you got a ceiling on your shoulders. You can do anything down here with weight. But I don't like this, especially with people with shoulder problems, okay? In a rehab setting. If I'm working with athletes that, want to do military press and so forth, I'm gonna show them how to do it right. But I don't love it in a rehab setting. But that's me. You may see that all the time where you're at. Ask them why. All right. Elbow, wrist, and hand. This has got a lot of review of anatomy and so forth in it. If I'm boring you with that, I'd rather just go on, just tell me. I figured most of the time to review that. So, the function. It's going to be a lever for us to bring things to us. We can rotate this forearm, we can do, if you don't have the ability to supinate and pronate, opening a door, turning a key, things like that are next to impossible. You have to rotate your whole body to do it. If you think about the arc of motion that we use at our elbow, it's about 100 degrees, okay? We need full flexion more than we need full extension. There's not many things that we're gonna do with our elbow completely extended. Matter of fact, you will see a lot of people, if you just notice people walking around, especially these big bulky guys, kind of like me, big studly guy. Camille, me and Camille, yeah. People with big biceps and so forth, they can't straighten their arms, okay? They don't need that. But you gotta have that full flexion to get, feed yourself and do your hair or whatever, okay? Supination is also about 50 degrees. You usually don't do much all the way in pure pronation or supination, okay? About 100 degrees. If you've got limitations of that, you're gonna have functional limitations. Elbow joint, we've got this. This is the definition of concave and convex. Big concave radius and ulna down here with a super convex distal humerus. Capitulum on the radial side, the trochlea on the ulnar side. Okay. That's an anterior and posterior view. See how it fits in here so nice and neat. Obviously we've got a proximal radiohumeral connection here, and then we've got a distal. Okay. And what's in between here? Interosseous membrane. I heard somebody say that. Lots of capsule and ligaments. We've got a MCL or a UCL. Remember, that's the same thing in the elbow. Or a lateral collateral ligament, or an RCL. You don't even hear that one much because that one doesn't get disrupted very much. What's the one that encircles the radial head? Annular ligament. Yes, sir.
Do you ever do oscillations for concave and convex surfaces?
So we're
it's
gonna do
so,
oscillations for this on that.
yeah,
It's a pretty stable joint. I won't say that I don't do them, but it's pretty rare.
pretty rare.
It's pretty rare. What I will do is I'll do some radial glides to try to improve supination, pronation. We'll practice that one. But the other ones, I mean, you really can't do much with this. This is locked in. This is like this. It just hinges. With the supination, pronation's got a little more play in it. You know, we got our annular ligament around that radial head. Here's the notches, okay? Really, really congruent. I mean, they just hooks right in there. Now, if you get a dislocation of the elbow, you know, we talked about if someone dislocates their shoulder, we just kind of traction it, it sucks back in there. If this thing dislocates, yeah, you're gonna have to knock them out, do all kinds of crazy stuff that I don't even know how in the world they get that back in there. More times than not, it'd be surgical procedure. But that, it's pretty rare.
With the elbow dislocation, is that usually more traumatic?
Oh, yeah.
For sure.
It's usually fall out of a tree house, arms sticking out, and you'll fracture here and dislocate here. I mean, it's usually something just grotesque. Yeah.
Because I've never seen it.
I have never. I don't think I've ever even treated one. It's usually they just stabilize them and just go. You know? We'll talk a little bit about that in a few minutes. Again, modified hinge joint, convex trochlea interfacing with the trochlear notch of the ulna, convex capitulum interfacing with the concave radial head. Now, which one of these fits better? Which one is more congruent and more stable? Which side? The trochlear side is much more like a hook deal, okay? You know what a radial head looks like. It doesn't really fit. So there's a lot of ligaments and a lot of play there. And that's why I think from a manual standpoint, we can impact that joint a little bit better. If that one gets stuck, we can do something with that. If the owner side gets stuck, tough, very tough. If you want to see more about arthrokinematics, you can go to these pages in your text. We know these are elbow flexors. We know these are extenders. We know these are supinators and these are pronators. Pretty easy, really. All right, so let's talk a little bit about the surgical procedures. Radial head fracture. So I've told you about my deputy sheriff, right? Guy that, yeah, had to shoot like a gangster. Could not supinate. This is what he had. Most common elbow fracture for sure. Usually a fouche. A lot of times has a dislocation involved with that, but obviously there's going to be ligamentous involvement as well. If you get a comminuted fracture, this is where it just kind of breaks apart. It just shatters. That's when you're probably looking at something that's more invasive. You're going to see more rigid fixation. I'll show you pictures of total radial head replacements. And then a lot of times, because this bone does not get a lot of great blood flow, so it doesn't heal very well. They can take it out. They can take that radial head completely out and just sew you back up and you can go, okay? That's somebody who's low demand. If we've got an elderly patient who's fallen and we don't want to bother with the whole total joint, you know, they've got anticipated 5-10 years to live or whatever, and they don't want to go through this whole process, they can just take it out. And I have seen a couple of those because it gets real necrotic and it just doesn't heal and it's just problematic.
So how does function change the patient's body?
It gets, you can imagine, they can't do a whole lot with it, but it's not real painful either, so. Goals of surgery, to relieve pain, restore the alignment and stability, and allow them to have some strength and functional use. Kind of common sense. So the excision or the arthroplasty is really about the same. You can go either way with this. but this is what it's gonna look like on x-ray, okay? If it's shattered like this, again, if it's an older person, they may just take it out. If it's a younger person, they're gonna replace it, okay? So just as any other surgical procedure, we've got complications, could be with a wound, infection. It certainly can get stiff. If you've got laxity with this, that's a problem. You've got a problem with the prosthesis or someone's done something wrong. Hopefully you're not gonna see a lot of pain. I mean, obviously there's incisional pain from surgery and so forth. Once that calms down, these total joints should feel really good because they're not arthritic because the joints aren't rubbing on one another. It's metal rubbing, so. Immobilization, they will put them in a splint. Let me see if I got a picture of that splint. Here it is. It's a pretty standard elbow splint that you will see. People who have a Tommy John surgery, pretty much everybody's gonna be in this kind of splint because you can see here, there's dials here that they can adjust the range of motion. So if they just wanna hold them at 75 degrees or whatever, they can do that. But it gives them support, it feels a lot better. Just protects everything a little bit. But it's a very common brace to see. Usually somewhere in that 75 to 90 degrees with a little bit more of supinations where they're gonna hold them. Something like this. It won't be like this. They'll try to open them up a little bit. So it's usually something like this that they'll be held in that position after they get the surgery. You can remove this for exercise, and you want to remove it for exercise, okay? It is dynamic. So again, you can adjust the hinges, you can unlock it, and they can move it. But again, right after surgery, they're not gonna want to move it a whole lot. You're gonna have to help them with that. And again, I don't want you to feel like this is not very common. This is not a huge procedure at all. Don't see it very often. I might see one of two of these a year. Again, big things: wound care, pain and control, range of motion exercises. But because if it's an arthroplasty, you can get this thing moving quicker. Okay, you can actually have them working on it. It doesn't have to be all passive because it's not really a repair; it's a replacement. Maintain mobility of unoperated joints. What do we got to think about here? Wrist and hand, big time shoulder. This is a problem. If I get somebody and they've had elbow surgery, I've seen it so many times, especially kids. They get in that sling and they're so worried about their elbow, they forget about this. And then you start having to do stuff and your shoulder's stiff. Well, guess what you got to do then? You got to treat the shoulder too. So start off right away with having them work on the shoulder. Have this scapular stuff going on, okay? Scapular clocks, isometrics for the shoulder. They can do all those things. Have them do that, okay? Do not forget about the mobility and stability of the shoulder. It is huge. You see minimize muscle atrophy with setting exercises. Have we talked about that at all? Setting exercises? That's the same thing as isometrics. Setting exercises equals isometrics. So if we want to have somebody and work on infraspinatus, we can have them in this brace doing this against the wall, or just holding right here and pushing against. That is a muscle setting exercise for infraspinatus. Same as isometric. A lot of times you'll see protocols that'll say setting as opposed to isometric. So here's detailed minimum of moderate protection phases. Again, once the wound is healed, movement's getting to where it's less painful, you can pretty much get after this because again, it's a joint replacement. And really, there's no change to the muscles. I don't think there's anything that they have to do. They just have, if you're getting to the radial head, You're just gonna have to move these wrist extensors to expose that. You don't have to cut them. So if you don't have to cut them, they just go back and they can do everything that they need to do. Okay? So you don't have to wait the 6 to 8 weeks, 12 weeks, whatever. You can get them moving. But what you're gonna see, if someone has this replacement, is they are not allowed to do high demand, high impact activities. And this is a must. This is why you're not gonna see this in many people. Because this procedure, this anatotal elbow, let me show you the restrictions here. Somewhere in here. No high weight. They can lift 1 pound for the first 3 months. They do not want these people loading these joints, okay? 1 pound is really light. That's a cup, okay? 2 months for 6 months, 2 pounds for 6 months, 5 pound limit thereafter. They're not lifting a gallon of milk. That's 10 pounds, okay? Not lifting it. So this is, again, this is reserved for older, more sedentary, less functional folks, okay? Don't jump, people do not jump into this surgery, all right? These are the components. That's what it looks like. You got a long stem, and they take this and ram it up in there into the humeral head. And then the radial part and the ulnar part, it's really intricate how they do all these types of things. They cement these in place. Precautions, they're gonna keep you, probably gonna start here, and it'll be very gradual how much range that they're gonna give you to begin with. It's gonna vary with the surgeon. Now, the triceps, they do have to, when they do a total, most of the time they have to cut the triceps to make it a total. So you can think about it. If I've got my arm like this, is the triceps stressed here? Not a ton. Where it's gonna get stressed is in full flexion. So you're gonna have a range of motion stop on here that will block that full flexion. For the most part, they're not gonna wanna fully flex it anyway. It's gonna hurt. So that'll probably be 3 to 4 weeks, maybe even a little bit longer. Okay. Hopefully stability is not an issue, but if it is, they will limit that full extension as well. Yes, sir.
Can you explain why they use that to cut the triceps again?
That's a great question. I do not know the answer to that. I know that obviously the triceps is coming down all the way to here. I think for them to replace that component, they have to lift that and then they have to put it back. I don't know the.
But it's not like they're cutting it, and basically putting it back.
Yes, it's always put it back. It's called a peel procedure is what they call it. They cut it and peel it back. They put the components in and they pull it back and suture it or however they do that. I don't know how. If there's ulnar nerve issues, flexion is the issue there, okay? That really tends to pull on that a little bit more than the extension does. Extension's gonna irritate the extensors, okay? The flexors of the elbow. But that, when you go into full flexion, you can get some pull along that ulnar groove, okay? That can be an issue. So you can limit that stop as well. So here you go. It's 6 to 12 weeks. That's what I was thinking. It was longer than that for the triceps. And apparently you don't have to do it because it says if involved. I don't know enough about that procedure. I don't see it very often. I've never sat in on one. So if we want to work and keep the shoulder strong, which we do, and they're in this brace for 6 to 12 weeks, we've got to put weight up here. We want them to do flexion, abduction. External rotation is really going to be, you're not going to put something here and have them do that, because that can impact here. Every bit of resistance needs to be above the elbow, on the distal aspect of the upper arm. Okay? So rotation would be hard to really do much for. And here they are in their functional activities. Avoid lifting and carrying objects for 6 weeks greater than a pound. Don't want to push open a door for, look, 6 weeks to 3 months, a long time, okay? Never more than 10 to 15 pounds on a single lift. No golf, volleyball, racket sports, no high loads or impact. So again, this is not somebody that's gonna have a really dynamic upper extremity after this. Okay? Breaks it down to maximum protection, pretty much the same with everything. Moderate and minimum protection. Usually by about 12 weeks, they can start doing most of their functional activities. And again, I'm talking about light stuff, brushing teeth, things like that. But again, this is not a procedure for a young person. You're not gonna see this unless something just dramatic happens. This is not gonna be a dynamic elbow. So if we look at collateral ligaments, this is a whole lot more common. These Tommy John procedures that these pictures have, the numbers are astronomical, how often this ligament is being replaced now. And they do this through this figure 8 technique here. They will take, again, what's this? Palmaris. They'll take that out, and this is what palmaris does. It winds through these tunnels that they will cut in the bone to make that new ulnar collateral ligament. If they don't have a palmaris, they can do a gracilis. They can do a hamstring. All you gotta have is a piece about that long. They gotta thread it through. Okay. There's all kinds of protocols. These are easy to find. Now, the other thing that they're starting to do is, and I don't even have this slide because this has been relatively recent, is they are using something called internal bracing. Ben Bossi had this procedure. So what they do is if the ligament is in pretty good shape and they're a young person, it doesn't have a whole lot of trauma on it, not a lot of fraying and everything, they can put a piece of collagen there that supports the ligament. They still do it's not what they call a reconstruction, but they place what they call an internal brace there with this collagen form. And the rehab is about cut in half. So if you have somebody with a Tommy John procedure, you got a baseball pitcher who has this done and needs a full reconstruction, they're probably 12 to 18 months from pitching at a competitive level again. Year and a half, year to year and a half, okay? With this internal bracing, and I think I saw 5 of them before I came down here to Alabama. In North Carolina, I saw 5, and they all did great, and they were back pitching in the 6 to 9 month window. So they almost cut it in half. How's Ben doing with his rehab? Is he throwing?
He'll start throwing probably the next month.
Yeah, he's doing well, from what I hear, yeah.
No, he's doing good.
Yeah.
Okay, but is that not like an issue though? Like with how quickly they're getting back on the mound?
Well,
Like even if like,
all the studies that they've done say this internal bracing is fantastic and makes perfect sense.
like
From a-
6 months after like surgery.
Yeah. The support that they have. Again, you can read all about it. Internal bracing. You're like, yes, ma'am.
So it's not like a temporary thing, like, so it's like, they wouldn't go back and do Tommy John later?
No. Well, I mean, if it tore again,
Yeah.
they'd have to do a full reconstruction.
It's not just like a quick fix kind of thing?
No, I mean, it's not a quick fix. It just cuts it about in half. About in half. Yes, sir.
So is it just for younger people and when it's not so bad of an injury?
It tends to be for younger people, because what happens, okay, I'm a terrible drawer, but if you've got if this is someone's UCL, okay, on the inside of their elbow, and if you've got somebody who's 35-year-old pitcher in the big leagues forever, and he's thrown for 25 years. He's gonna have bone spurs all around through here, okay? And that frays this thing big time. That is not somebody that's gonna do well with this internal bracing. But if you've got a younger person, like we're talking about this pitcher at Auburn, he tore it at one specific site. So basically they place something here. This internal brace is a collagen mesh support system that they can put on here. And again, if it's just torn in one section like that, it works really well for that. But if it's blown out completely, that's not somebody that's a good candidate for that. And that's a surgical criteria that I don't really understand all that stuff. But the rehab is much more accelerated. Okay. You're gonna continue to see tons and tons of these. I've seen as young as 11 years old. Think how bad that is. You got some kid who's 9 and 10 years old throwing so much that he's gonna blow out his elbow. It happens now. It's ridiculous.
Have you ever had somebody that's came to you and tried to get that done without
Yep.
anything being?
Yep. So a lot of them will say, hey, so-and-so had Tommy John and he's throwing harder. Well, it's not because he got a new ligament, it's because he went through rehab. And he's gotten his shoulders stronger, he's got his core stronger, he's got his hips more mobile. All of his technique is better. He's got a pitching cut. There's a million reasons. It doesn't have anything to do with that ligament. So yeah, but I hear it all the time. I hear it all the time. Oh, the ruination of youth sports. Parents. I had a kid, so I was coaching my son's team. Kid was 11 years old. He's our best player. Smaller kid, but really skilled. Just played baseball all the time. So ours was like rec league. So we would practice once a week, maybe twice a week, and we had games mainly on Saturday and one during the week. So we're there 3 to 4 days a week for a couple hours. Nothing crazy or anything. Well, little did I know that his dad had him pitching in another league. So he's getting, and we pitched him some as well. I mean, he was our best player, so I'm gonna have him pitch because he threw strikes and he threw hard and all that stuff. But if we played on Saturday, he's going over here and pitching on Sunday. Until he comes to me one day, he goes, "My arm doesn't feel very good." I looked at him because he wouldn't say anything. He's throwing and he doesn't have his velocity, and I can see him kind of holding his arm a little bit. I said, "Braden, what is wrong with you?" He says, "Well, I threw about 120 pitches last night." I'm like, "What are you talking about?" "Yeah, we had a game. We had a travel ball game, blah, blah, blah." His dad's standing right back over here watching the whole thing. And I go over to him and said, "He's not to pick up a ball. He shouldn't pick up a ball probably for 2 weeks. He's not going to throw here. He can hit and that's it." And Dad gets mad at me. "What do you mean he can't play?" I say, "He can't throw. He's not throwing. Threw too much." It's just crazy. Crazy stuff. Had surgery when he was 14. I did his rehab. All right, getting out of the bad parents. Let's talk about let's talk about my mother-in-law. How about that one? I told you about that one. She is small, frail Eastern European lady. She has had 2 Colles fractures. I told you about the one at Jordan Hare, right? So we come out, this is back in 2009. We're playing Arkansas. Of course, we've never beat Arkansas. I've never seen us beat Arkansas. Come out, we lose, and it starts raining. And if y'all been in the stadium, if you walk around on the east side, the hill that goes right between the baseball field and the in the football stadium. It's pretty steep. And of course, there's 8 million people walking out. We're all kind of walking together. I think I've got my son up on my shoulders or something like that. And I see somebody go down over here. And I'm like, the damn drunks can't even get out of the stadium. I look and it's my mother-in-law. And I look down and her eyes are this big and her radius is sticking like this.
It's like out of skin.
No, it's not out of the skin, but she's got another elbow right here. It's bent this way. I'm like, oh gosh. So I put my kid down and walk. Luckily, there's an ambulance right there at the bottom of the hill. Get her to the ambulance. And he goes, do you want us to take her to the ER? And she's like, I'm not going to the ER. It's Saturday night in Auburn at a football weekend. She goes, I'm not going to the ER. I'm not going to the ER. I said, okay, you don't have to. So we take her back to the hotel room. One of the people on the golf cart took her back to the hotel. I think she was staying at the conference center or somewhere. Get her back in the room, and luckily I had pain medication. I go and give her two pain meds. She goes to sleep. We splinted it. We did something, wrapped it in somehow, shape, or form. And they drive back to Winston-Salem. I call the surgeon. I'm like, my mother-in-law is coming to see you. It is Sunday. I need you to see her. He's like, sure, no problem. And she was in surgery on Monday, and she had an external fixator. Has anybody seen these before? I don't know if I have a picture of one. Let me pull one up. Yeah. Fine, these are all lower half.
That's what I was saying.
This is what she had right here, exactly. She had that walking around. Man, again, my mother-in-law's arms, she's tiny. She's tiny. She couldn't even lift her arm with this external fixator. I mean, she's got screws coming out every which way. She's got plates, pins, all this stuff. She's just walking. She's the most pitiful thing. She's just walking around. Finally, she gets it out of. They take the things off. It's 6 weeks later, whatever. The bone is healed again. She's osteoporotic and all this stuff. Super frail. We start doing rehab. Things come along. She does okay. We're doing a lot of gripping stuff. We'll talk about in lab today. And I didn't dare treat her. I sent her to a friend of mine that was an OT. But I go by. And I said, well, show me your exercises. Show me your homework. Wasn't doing them. She got to the point where she couldn't open a door. She would type and get fatigued and all this stuff. I was like, damn it, lady. If nothing else, just keep gripping something. And she, terrible. Don't ever treat your family members, ever. The worst patients ever. So that was in 2009. Oh, no, she broke it before in 2006. She came out of an RV when they were in Alaska. She always does it on the road. Comes out of the RV and misses the last step. Boom. Snaps the other one. So she's had both of them done. The one was really bad. The one at Auburn was horrible. She had that one for that one. But, yeah. Moral of the story, don't treat family members. Smith's fracture is less common. It's the volar displacement. So that comes this way, as opposed to Colley's comes dorsally. So the volar one, you hit here, and this radius goes down like this. But more common is this to happen, and it pops out this way. And yes, they can be compound pretty frequently. This has got to be radius down and all the way here. This is brutal here. Gosh, it's awful. All right, the more common injury is just the repetitive stresses and strains of the soft tissue. The epicondylitis, both medial and lateral. Which one's tennis elbow? Lateral. Therefore, golfers on the inside. So I played 45 holes, no, 54 holes Friday, Saturday, Sunday. It's red hot right there. Yeah, I iced it last night. So I should be doing my exercises as well. I will stretch a lot. That's probably about it. I just won't play for the rest of the week. This is related to excessive flexion and extension strains for the most part. Mine's more about pronation and supination. This is something I really want you guys to understand. Has anybody heard the term tendinosis before? Go back to your med term. You remember what osis means? We know what itis means, right? That's inflammation. Osis, degradation, breakdown, okay? So this is the tendon that has degenerative changes, and there's not inflammation. This is a continuum. You have tendinitis, and if you have tendinitis long enough, frequent enough, chronic enough, it will turn into tendinosis. It doesn't just happen automatically. Okay? These changes occur immature fibroblastic and vascular elements and weakening of the tendinous structure. So it actually breaks down. The contractile tissue, the connective tissue breaks down. And you get more of this fibrotic tissue. You get scarring within the tendon. So therefore it's weaker. Okay? Nerve ingrowth. You've stimulated the nerve reacts. This causes more pain. That's not even related to inflammation. Has anybody experienced tendinitis repeatedly? What you got? Yep. It's been a while, huh? Probably got some of this going on. Leo, what'd you have? Your knee, like patellar tendon? Yeah. Not as common. Not as common because you, for the most part, I mean, unless you're doing repeated squats, more dynamic lunges and things like that. Certainly more of the hands and stuff. How about yourself?
Tennis elbow from doing landscaping for years and years,
Yep.
holding that weed eater,
Yep.
edging and stuff.
That vibration.
Yeah,
that
I had to wear
torque.
a brace for a long time.
Yeah.
Can you explain the nerve ingrowth?
Yeah, okay. So obviously you have nerves and you have nerve endings. The nerve endings, obviously, when you have inflammation, they get inflamed as well and they have swelling and things hurt and it goes to your brain and tells you something hurts. When you have this much inflammation that occurs, and even the inflammation calms down, the nerve gets stimulated. And within the structure, the nerve changes its structure too. It's kind of like Wolff's Law type of
So
thing.
from the compression?
Yes, from the injury, the repeatedness of the chronicity of the
Should
injury.
it be like chronic?
Yes, chronic. People that have tendinitis once, they don't get this. Okay. But you've had it for quite a while. There's probably not inflammation present, but you still have pain. So what is the cause of the pain? It's this, it's that nerve ingrowth.
So does it just turn into, like, symptoms turn into tingling and shooting and stuff?
Yeah, you can have some of that. Yes, sir.
So do you see a lot of tendinosis or tendinosis?
Tendinosis?
Yeah. Because like they've been dealing with that pain for a while and then eventually.
Yeah.
There's no more inflammation, but it's painful still.
Unfortunately, we probably don't see enough of it. What I'd rather see is tendinitis. I know we can help with that. We can use modalities, we can rest them, we can put them in a brace. We'll talk about all that stuff. Stretch them, eventually strengthen them, and they're usually pretty good. But if they keep having tendinitis and it keeps flaring and flaring and flaring, and it gets to that tendinosis, it's hard to do much with it.
So how do you treat it?
How do you treat it? Well, we'll talk a little bit about that. Hang on, a couple slides here. Lateral. Is yours lateral? Should it be lateral? So lateral epicondylosis, okay? Pain in common with wrist extensors, gripping, extension activities, mostly gonna be at the musculotendinous junction of the extensor carpi radialis brevis. You know all these things, tenderness, pain with resistive extension, raised middle finger, you remember our little test there. Passive wrist flexion, elbow extension, elbow pronation. That's the way you stretch it, but that can also be painful for it as well. Okay. Medial's just the opposite. Pain in that common flexor, that's me right now. Pain with passive extension and elbow extension. And supination will get that going too. What you're gonna try to do with this, again, if it's tendonitis, all the stuff we talked about, rest, anti-inflammatories, bracing, stretching, eventually strengthening. If you got somebody with tendinopathy, you're gonna wanna do a little bit more of this eccentric exercise. So the etiology, how this occurs, is repetitive use of eccentrics, creates that micro damage, sees the strength of the rate of repair. We should be able to heal ourselves, but we just keep doing what we do, and it becomes more problematic. This creates the inflammation and starts to lead to this tendinosis where it breaks down. Because our body fights inflammation systemically, okay? That's what ends up causing tendinosis. So what are we gonna do about that? This is what you're gonna see. You're gonna see gradual increase, pain and stretch, tenderness. This is what we do for the itis, stuff we just talked about. Cock up splint, that's the first thing I do. If Cameron came into me and said, I've been lifting weights, I've got medial pain here or lateral pain here, I'm gonna put him in a cock up splint, which costs $12 on Amazon or CVS overnight, and put his tendons, his extensors or his flexors in a neutral position, okay? Allows things to calm down, because we know that this or this is what's gonna make it worse. So let's put them in this short and neutral position. That's resting, okay? We're gonna tell them avoid the aggravating activities. Don't lift weights for a few weeks. Don't weed eat. Don't play golf. Does any of people listen to these things? No. No. They're usually pretty good about wearing this brace overnight because it's just easy to do. But as soon as you tell them what they can't do, that's where you get in trouble, okay? Cryotherapy, obviously, we can use ice on both sides there, no problem at all. We will stretch, told you that. Cross friction massage. Have you done that before? Can be helpful. Increase the blood flow, get things moving a little bit there. Fluid exchange. Eccentric resistive training. Okay, so if they're in pain, they're not gonna be able to do this. But what we wanna try to do is strengthen the extensors, or the flexors, or the pronators. Strengthening through eccentrics, because that's how they got hurt in the first place. We want to be able to increase the load, but we can't do it if it's inflamed. We gotta do all this other stuff before. Achilles tendonitis. That's another good one, okay? If you've got somebody with Achilles tendonitis, once things calm down, I will have them do tons and tons of these eccentrics. I'll have them go up with 2, down with 1, okay? There's a great study on that. That if you can do 30 reps like 3 times a day, you will not have tendinosis. It's almost like 100%. But people don't do it. They don't keep up with it. It's a lot. They get really sore. I gotta find that study for you guys. It's a really good study. Elbow flexion contractures. So this is one of the most common things to use this dynamic splints. We talked about how it's more common to have a flexion contracture, maybe losing 30 degrees of flexion or whatever. What they do is they put a brace on, it looks pretty similar to the one we just looked at, except down here, it's got a crank on it. And it will put them in extension, and you twist this dial, and it will slowly extend them more, okay? Now, it's not gonna feel very good to their bicep and everything else, so you gotta go very slowly with this. I don't know how much PTAs will deal with this, but you'll see these braces for sure. There's reps that come in. This is called Dynasplint, dynamic splinting. It's a self-stretch. You teach the patient how to do this. And they wear this brace 24/7. Just take it off when they go in the shower. And it puts a constant low load prolonged stretch on that tendon. It works great. It's expensive, it's bulky. People don't like wearing them, but they work. Okay? And you can do these for any joint in the body for the most part. Especially knees. I'll use it sometimes for shoulder, for external rotation. If we get, there's a thing they basically sit in like this. Again, it's expensive, but if they haven't responded to anything else, and it cranks their arm out this way. Unfortunately, insurance sometimes covers it, sometimes it doesn't. So sometimes people are paying out of pocket, and these would cost like $500 a month to rent. The brace itself would be several $1,000s. But they work. Let's come back after lunch and we'll talk about this. Any questions on